Thank you. First of all, I'm really glad to have been invited to this talk. Before we start, can we just ask Georgie and the rest of the organizers to stand up and let's give them a big round of applause. All the hard work they've done. Thank you. It's very tough to follow Walter and Leo, so I'll try my best. I'm going to be talking about an update on lowering therapy, and this is meant for a general audience, for you, if I am unaffiliated. I have no disclosure, but it's the employee of the Japanese Affairs that's supposed to say confidently about does not represent the views of the VA or the
Hindi ka doctor mo tinanggalan mo.
We're going to be talking in general about a review of the role of LDL cholesterol in atherosclerotic cardiovascular disease and trials showing the relationship between LDL lowering and reduction of ACE or major adverse cardiovascular disease. Recently, there's been new guidelines as far as lipid lowering. Talking about important highlights in the American College of Cardiology, American Heart Association guidelines. And lastly, as a good future, I'm going to summarize the data on the PCSK9, which is the next phase of lipid lowering therapy. We all know, even from medical school, that it's been established epidemiologically that. Sorry, can you hear me now?
Yes.
It has been, we all know from medical school that it has been established epidemiologically that the relationship between the incidence of coronary heart disease and the incidence of cholesterol level is a direct relation. In the Western Hemisphere, with the advent of dietary changes as well as changes in physical activity, there has been an increasing trend in obesity, which obviously is very concerning. Now, the Philippines has a very rich culinary tradition of, street foods like Adidas, IUD, Walkman, and Betamax. I was walking through Mabini, and I see some of them, and I was tempted. And so, the implication for this is that, according to the 8th National Nutrition Survey in the Philippines, there has been an increase in the number of the prevalence of high cholesterol levels in the Philippines. And more alarmingly, there's been still an increase from 2008 to 2013. So what used to be a Western problem is now involving third world countries like the Philippines. This is very relevant because of the primacy of LDL cholesterol as a risk factor. We all know that there are many risk factors to cardiovascular disease, including cholesterol, hypertension, smoking, diabetes. But what is under-recognized is that LDL cholesterol, or non-HDL cholesterol, is the unifying factor among all these risk factors for atherogenesis. It plays a very central role among all cardiovascular risk factors. This graph shows that LDL alone without any other risk factor confers an increased risk of cardiovascular disease, but in the setting of the presence of other risk factors such as diabetes, metabolic syndrome, smoking, or hypertension, there is still an increase in incidence of risk for cardiovascular disease in the presence of high cholesterol levels. So the fact that the cholesterol levels are increasing in the Philippines has very important implications because the incidence of obesity in adolescents and adults in the Philippines are also increasing, as well as the incidence of diabetes and hypertension. So within the last decade, the profile of the Philippines is increasing the Western profile. And so it's really important for us to understand how to lower LDL cholesterol in this even in the Philippines. The good news is many decades of research among many clinical trials have shown that whether it's primary prevention or on secondary prevention, lipid lowering therapy has shown that it reduces event rates for cardiovascular events. So, in the spirit of Boston Hall, I'm going to be asking some questions. I don't know if Boston Hall is still relevant here, but I think it was very relevant to us. And how many cardiologists are in the room? So we will be asking the one cardiologist here. I'm kidding. So question number one, the decrease in cardiovascular risk in relationship to LDL is determined by A, global risk of the patient, B, percent reduction in LDL, C, final LDL level, and D, the absolute reduction in LDL.
May price ba? May price? May price?
No price. So the answer is C, the absolute reduction in LDL. And this is actually a very, very important point. If you look at all the trials on lipid lowering, there is a direct relationship between the absolute amount of reduction in LDL, whether we use the national units or the English units, as we still do in the US, with the reduction in rate of major adverse events. And in fact, do you guys use SI units or do you use, okay, so for every 1 millimeter reduction in LDL, there's a corresponding 20% reduction in cardiovascular events. This is a very, very important concept. Question number two. The degree of cardiovascular risk reduction depends on the type of drug agent used to lower LDL, e.g., for example, statins versus statins, or the extent of lowering of LDL, or both. That's what the statin manufacturers would like us to believe, but it's actually the extent of lowering of LDL. And let me give you the rationale or the evidence for that. If you look at many agents, both pharmacologic and non-pharmacologic means of lowering LDL, different approaches lower LDL in different magnitudes, but they all lower it. Diet, for example, lowers it by 10%. Fibrates lower it by 15%. Ezetimibe by about 17%. Even surgeons have a way of reducing LDL. LDL exclusion causes a reduction about 30%. And statins, the high doses cause about a 40-50% reduction. And we'll be talking about the PCSK9 inhibitors, which causes that. So it really does not matter what agent you use, so long as you achieve the same amount of LDL lowering. And so drug reps may tell you that one is better than the other, but so long as you achieve the amount of LDL reduction, the amount of reduction in vascular events will be similar. So we used to think of statins as having both a LDL lowering effect as well as a reduction, an additional reduction because of its quote-unquote pleiotropic, antioxidant, anti-inflammatory effect. What this means, this theory, is that over and above the LDL lowering, statins increase the benefit as far as event reduction because of this pleiotropic effect. But is this really true? Recently, just within the last couple of years, the improvement trial showed in about 40,000 patients that adding ezetimibe to simvastatin reduced the event rate for major adverse cardiovascular event. And it showed that just a difference of 0.4 millimeters per liter showed a reduction in events. As you know, ezetimibe reduces cholesterol absorption and has nothing to do with anti-inflammatory or antioxidant effects. And when you graph or plot the reduction, the amount of reduction in LDL, of improvement, it lies exactly in the same as predicted by all the trials. In other words, the reduction in events from any drug causing LDL reduction is due mainly and only because of LDL reduction, not anything else. Third question. I only have 5 questions. So, the 2013 ACC AHA Cholesterol Treatment Guidelines, which followed the previous guideline, lowered the target goal of ideal LDL to 1.8 millimoles per liter in patients with high cardiovascular risk. True or false? So the answer is false. We used to know this by heart. The NCEP and ADP3 guidelines say that the optimal LDL cholesterol level is less than 100, and the desirable total cholesterol is less than 200. And so physicians for a decade have been trying to target these goals as far as titrating their lipid-lowering therapy. But importantly, the new guideline removed this target, and I'll be explaining why they did this. So, in summary, the new guideline says that the first-line agent for lipid-lowering therapy is statins, and you should target 4 groups to reduce the major adverse cardiovascular effects. The first group is those with established disease, so this is a secondary prevention. The other groups are primary prevention, those with LDL levels greater than 4.9, those with diabetes and LDL levels that are 70 to 189, recognizing that diabetes is a very important risk factor for cardiovascular events. If a patient does not have diabetes, is 40 to 75 years old, but when you calculate their estimated 10-year risk of cardiovascular disease is greater than 7.5%, or even 5.7%, which is a moderate strength evidence, you should also consider statin therapy. If you cannot calculate quantitatively what their 10-year risk is, you should consider the following risk factors as driving you towards starting statin therapy: family history, LDL greater than 4.1, a coronary calcium score of less than 300, high sensitivity CRP of greater than 2, and an ankle brachial index of less than 0.9. Risk factors for adverse cardiovascular events. Why did they remove the target levels? The committee said that there is no direct data from randomized controlled trials that confirm the efficacy of using target LDL for therapy. And so they recommend the standard doses used in randomized controlled trials, so they don't provide less guidance on titration. And they classify statin therapy as high, moderate, or low, depending on the amount of LDL that it causes. Now, as far as cardiovascular risk calculator, the American College of Cardiology emphasized that for each patient you should calculate this risk, and it's available online, or you can download it as an app. For example, in this particular case, the 10-year risk factor is about 14.3%, which is a pretty high risk. However, despite doing statin therapy, there are still people who are candidates for other therapies. Either they have familial hypercholesterolemia or statins are not enough, patients who are intolerant to statins, or patients who need further reduction because the statins are not enough. And what do we do for them? Right now, the first-line agent is ezetimibe, because among the non-statins alone, it has shown the highest added LDL reduction effect. But question number 4. This is a mouthful, but the pro-protein convertase subtilisin caxin type 9, otherwise known as PCSK9, which is a new wonder drug, act by A, decreasing cholesterol synthesis, regulating LDL receptor cycling, bile acid sequestration, gain of function mutation results in decreased plasma LDL. So I have an answer here that the longest choice is usually the correct answer. It actually is good. It regulates LDL receptor recycling. I think this is a very important point because within the next 5 years, PCSK9 inhibitors will likely form a major role in your armamentarium for lipid lowering therapy. And this comes from a very important observation of patients, and they look at gene polymorphisms of the gene for PCSK9. And they showed that people with gain of function polymorphisms, meaning more PCSK9, showed higher levels of LDL cholesterol, whereas those with loss of function, or they have less PCSK9, have reduced LDL. And when they compared people with high PCSK9 versus those with low PCSK9, they showed that the coronary heart disease incidence in these individuals who were lucky genetically to have a significantly lower incidence of coronary heart disease. How does PCSK9 work? I'll just take a few seconds to tell you how LDL receptor recycling goes. So LDL is produced, the LDL receptor is produced, it goes to the cell surface, it binds LDL particles that's circulating in the blood and puts them intracellularly, and then so that lowers the LDL cholesterol level, and then the LDL receptors recycle to do its functioning. So in a functioning LDL receptor, it sort of removes LDL from the circulation. The same signaling mechanism that increases the LDL receptors also produces the PCSK9 protein, which is excreted by hepatocytes into the bloodstream. This PCSK9 associates with the LDL receptor, but when it's associated, it prevents the LDL receptor from being recycled. Therefore, it acts by downregulating LDL receptors. When you downregulate LDL receptors, there is a net increase in cholesterol. Currently, the FDA has approved 2 medications which are monoclonal antibodies against PCSK9, aliricumab and evolocumab. And unlike other medications, they are given subcutaneously. So these are injections. And so far, they have shown that there's about a 50% reduction in LDL cholesterol, but the indication is only for those with familial hypercholesterolemia or for those with cardiovascular disease who are either intolerant to statins or who are already on maximally tolerated statin dose. As far as mortality reduction, the trials are still ongoing, but so far there is preliminary indication that there is an improvement in mortality. Like I said, this is just preliminary, and we need to wait for results from long-term randomized controlled trials, which are still pending. As far as adverse outcomes, there is no significant change compared to placebo. Last question. There is strong evidence that lowering LDL below 0.6 is associated with adverse clinical outcomes, meaning if you lower the LDL cholesterol to very, very low levels, is it actually bad for you? So when they look at the population, there are actually a certain population of people with a double mutation, double loss of function of mutation of the PCSK9. And in these patients, there are very, very low levels of LDL, approximately 1.4 millimeters per liter. And these patients, or these individuals, have no increase in morbidity or mortality. So in a population of people who are lucky enough to have almost non-existent LDL levels, they're doing fine. And in trials for the PCSK9, they achieved about 37% or 25% of patients achieved very, very low levels of LDL, and they showed that there is no increase in adverse event. However, again, as a warning, long-term safety remains to be determined, so we need to await long-term results of randomized controlled trials. So this is probably the most important point that summarizes the take-home points. LDL is the driver of cardiovascular disease among various risk factors. The reduction in cardiovascular risk is determined by the absolute reduction in LDL. As regards LDL lowering, agent may not matter, no matter what your drug rep says, so long as you achieve it. And the principle is the lower the better, the longer the better. However, somewhat counterintuitively, the 2013 guidelines veer away from prescribing target goals. And more promising for the future, the inhibition of PCSK9 affords a new and very powerful agent to lower LDL on top of maximum statins. Thank you very much.
Okay, thank you, Raymond. And I'd like to invite Wally Tan to come up so we can answer some questions. We'll have a question and answer part for about 10 minutes. If not, we'll go straight to a break. Anybody have questions?
Nag-breakfast na at daw.
Kakanta muna ako. Okay, I'm internist in El Paso, Texas, no? So I see a lot of these diabetics, hypertensive patients. With the Mexican diet, their triglycerides are usually really sky high, between 500 and 1,000. So, in those patients, are there studies that still support the idea that elevated triglycerides are accompanied by an increased risk of heart disease?
This is actually a very, very important question. Right now, the risk factors actually should be considered non-HDL cholesterol. So both LDL cholesterol as well as VLDL cholesterol and triglycerides are part of that, are actually known risk factors. So when we talk about LDL cholesterol, what we really should be talking about is non-HDL cholesterol that includes triglyceride. And fortunately, the distinction is not very important clinically because most of the agents that lower LDL also lowers triglyceride. But you're right, in diabetics, for example, where the main problem is hypertriglyceridemia, you may modify your regimen so that you can make sure that the triglycerides level are less than 200 or whatever your goal is. So that's a very important question.